afternoon. Welcome. My name is Hans Kaczynski, and I'm the Chief Executive Officer of the upcoming hospital Novacare. And today is our first public performance. He's a clinical director in Imperial private healthcare. He is well known in research. He's an advisor to the NHS and whoever you think is important in the United Kingdom when it comes to vascular surgery, he's there. So thank you very much, and Professor Davies, it's up to you.
Thank you very much. Right, well, it's a great pleasure to talk to all of you this evening, and I apologise if some of it is too basic for some people and if it's too complex for others. If there is something that you want to ask while I'm doing it, put your hand up. I have no issue about doing that, and I hope for some of you who may be non-medical there will be some interesting take-home messages, particularly for those of you that seem to like to fly or to travel. Now, what is important for you just to think about is that in Pakistan itself, 200,000 people die per year because of a pulmonary embolus. So just bear that in mind, and for every fatal pulmonary embolus there are at least 5 that are non-fatal, and for every PE there probably are anything up to 10 DVTs. So this is some Pakistani data from 2013, if I've got the years right, and it's very much highlights within the Pakistani population that VTE is neglected. There's not enough talked about prevention of what goes on, particularly with people who are hospitalized, and the incidence rate of VTE within the population is somewhere between 2 and 13%. If we then look at this data that came out in 2024, again Pakistani data, basically very much highlighting that VTE risk assessment is not being done in the hospitalized population, and that it has been quite a challenge to integrate it into practice. Now, I obviously don't know what the problems have been integrating it into practice, but really I just wanted you to have this as some background as to where my lecture may be of use to you in the future. Now, deep vein thrombosis, as you can see, is common. You can end up having a pulmonary embolus. You can end up having the post-thrombotic syndrome, which is a problem with your legs where you get swelling and aching, or you can be completely asymptomatic. Or you can be one of those unfortunate individuals who's had one DVT or PE, and 5% of people, despite treatment, will go on and have another VTE event. If you have a PE, you might die, you may end up with pulmonary hypertension, or you might have recurrent VTEs. Or again, it may be asymptomatic. But the post-thrombotic syndrome is something that I have a major interest in, because you will see there a patient with leg ulceration, and if you have a DVT, you have up to a 50% chance of developing the post-thrombotic syndrome, which is a large, heavy, swollen leg. You will get pain on walking, and of that, those 5 to 10% will go on to develop leg ulceration. So I'm going to take this in order to talk about prevention of DVT. I'm then going to talk to you a little bit about superficial vein thrombosis, and then the actual management of DVT. I can't highlight enough to you that patients who are hospitalized are at an increased risk of getting a deep vein thrombosis. In the UK and in the United States, there has been a big push, and this started in around 2005 in the United Kingdom, where it was found that we were having 25,000 excessive deaths in hospitals that were related to VTE. And this has led to a whole program of work to introduce VTE prophylaxis and various risk assessment tools, and such that in 2010, hospitals were actually rewarded if they met certain criteria with respect to sorting out VTE prophylaxis. Now, one of the issues with VTE prophylaxis is you have to look at the VTE risk, what the intervention is, and if you are going to use drugs, what is the bleeding risk, so what actually is the benefit. Now, this you could regard as sensationalism, but is two recent examples in the UK of young ladies, women, who have died having varicose vein procedures because they weren't given appropriate prophylaxis. Now, what is used globally in many institutions and in various hospitals in the United States, you will have the Caprini score, and Medicare, etc., will expect them to perform and have at least 95% of people to have had an appropriate risk assessment. Now, you obviously can't read this in depth, but there are the obvious things such as obesity, age, hormone replacement, all which will fit into putting you at a risk. And can I just ask, how many of you were working in hospitals and are familiar with doing risk assessments for VTE? Okay, so some of you are, so I apologize if I'm preaching to the people already converted. Now, the types of prophylaxis can obviously be drugs, heparin, warfarin, antiplatelets. There can be mechanical, such as stockings, pneumatic compression, neuromuscular stimulation. And probably the most important thing is actually getting your patients mobile. But what is very important is that surgery probably accounts for anything up to a 25% of the reasons why people go on to have a VTE. And things like orthopedics and neurosurgery are the cases with major abdominal surgery that put you at highest risk of developing a VTE. Now, this is just a sole example from the NICE guidance looking at patients who are having abdominal and thoracic surgery. And you can see that as you increase the risk, there's a suggestion that you should go for mechanical, pharmacological, and then potentially extended prophylaxis when the person is discharged from hospital, and it may then be suggested that they have a week, a month, or 6 weeks of what we are now using mainly DOACs, but to have an extended chemoprophylaxis. Now, we've talked about stockings, and I just wanted to give you some evidence of some of the research that we've done. This is called the GAPS trial, where we wanted to look at and see if there was any benefit of patients who are at moderate or high risk during surgery having stockings as well as low molecular weight heparin injections. And this study very clearly showed that you did not need to wear stockings as well as have the injections. And in the NHS, and this is just being adopted by NHS England, is actually going to save the NHS £60 million a year. We're also running a study looking at those patients who are at very low risk, because often in the UK you're having day surgery, the nurses will throw a pair of TED stockings on to somebody and suggest that they put them on. This is just about to be submitted to the New England Journal of Medicine, so I can't tell you what the result is. And then we're also doing a study, again looking at the benefits of stocking in that extended prophylactic group to see whether there is any benefit of wearing stockings if you're going to carry on chemoprophylaxis in terms of drugs at home. For those of you who may or may not be familiar with the use of IVC filters, the basic message is that IVC filters are completely and utterly a waste of time, and they're probably put in far too often. The US has shown that. The only real indication to put a VTE IVC filter in is somebody who is having recurrent PEs on adequate anticoagulation or for some reason cannot take anticoagulation. This is just to show you some of the alternatives to stockings, and one of the things that certainly is undoubtedly probably mandated in patients post-surgery and people post-stroke is actually to use a pneumatic compression device, and the whole theory about that is that it helps with the calf muscle pump of getting blood out to the calf and actually preventing stasis, which leads to a DVT. This is just some data really just from the Cochrane review, really reinforcing the importance of pneumatic compression in hospitalized patients. How many of you in the audience like to travel? Good, all of you. How many of you think about the risk of DVT when you travel? Oh, good. I'm glad some of you think about the risk. That's good. How many of you think if you're going on a long bus ride, you think about it? Long car journey, think about it. Right, now, in flight, there's very much been coined this phrase, the economy class syndrome. And there are some things that you need to think about, first of all, from the aircraft point of view. The oxygen in the cabin is not as good as it should be, so that actually tends to make your blood a little bit more sticky, as does the low humidity. But if we want to just look at the person effects, you tend to be immobile, and if you are immobile for more than 8 hours, your thrombin makes you a little bit more sticky, and you're at an increased risk. If you're slightly overweight, you don't empty the blood from your legs as well, and that increases your risk. If you've got a known thrombophilia, you're also at around about a 16-fold increased risk of having a VTE. If you have got known cancer, you are at an 18-fold risk of getting a DVT if you're traveling by plane. The oral contraceptive pill probably puts your risk up 4-fold. Hormonal replacement in the oral form probably puts it up 2-fold, but if you're doing it in a transdermal format, it probably doesn't matter. And the jury is out as to the effect of smoking and diabetes. And I apologise for some reason on the conversion to the system here, those slides have slightly metamorphosed. So, I've highlighted the problem to you. Some of us are getting on a plane later on this evening. So you can think of all the things that you should do. Get up and walk about every 2 hours, but hopefully on the plane I'm going to sleep for 6 or 8 hours, so I'm not going to be doing that. Yes, I will certainly be getting out of a suit and jacket and be putting some looser clothes on. You want the clothes to be baggy. You want to stay well hydrated. You want to avoid alcohol, particularly while traveling. Now, I would show you my legs, but I gather that's inappropriate in Pakistan, but I have already put my compression hosiery on of type 2 up to my knee to wear on the flight. And the two pluses of that are that it reduces the swelling, but it also reduces my DVT rate by 90%. And I'm going to ask my two colleagues who are traveling with me whether they're wearing them or not, because I've got a funny feeling that they're not. But you could take the argument they're not as high risk as I am because I'm older and I might be a bit tubbier. But the other question comes, what do you do with somebody who has previously had a DVT, is no longer on anticoagulation, or has some other risk factors, or is having chemotherapy, other things? There is quite good evidence that actually to give these people anticoagulants or aspirin, what we tend to do in the UK, there's no good evidence for this, we tend to recommend if you're doing a long-haul flight, we would recommend that you take a DOAC on the morning of the flight and for the 2 successive days, and the same on the return journey. There's no good evidence for that, but that is where the current recommendations happen to be. And there is now some evidence to suggest that aspirin is of some benefit. So the take-home message on prophylaxis is just think about it, use whatever guideline your institution uses, but the key thing is think about it and take a good history. Now, superficial vein thrombosis, certainly when I was at medical school, we were just told, oh, it happens, it's relatively inconsequential, you don't have to worry about it. Well, the answer is that is yesterday's news. The straightforward answer is it is something that should be taken very seriously. This is our UK NICE guidance, which I was involved in writing as the chair of the NICE Guidance Committee, and it was very clear that if you have a superficial vein thrombosis, you should be referred to a vascular specialist. The things that are associated with developing an SVT are age, being male, being obese, underlying thrombophilia. Some of you may have been taught at medical school that this was one of the indications for doing venous surgery and ligating the vein and doing something acutely. Well, the straightforward answer, there is absolutely no indication whatsoever for doing surgery or venous ablation or anything like that. there is some discussion as to what you should do with respect to anticoagulation regimen. Now, this is the European Society of Vascular Surgery's recommendations, which is the latest that came out in 2023. The first thing you must do is actually, when presented with a patient, get a duplex of the leg to make sure that it's the superficial vein and whether there's any extension into the deep vein. The straightforward answer is we then start talking about 3 centimeters from the junction and 5 centimeters in length. This only comes purely from the Callisto study, and you will find that the majority of people, if there is an extensive SVT, will now anticoagulate people, and even though the original studies were done using fondoxaparin, it's probably very well accepted that most people would now just use a DOAC. Now, does anybody have any questions about SVT before I go and start talking about the management of DVT? Or I can happily take questions at the end. Now, here you can see quite an obvious swollen leg. First diagnosis is that of a deep vein thrombosis. Now, how do you make the diagnosis of a deep vein thrombosis? It's 12 midnight on a Saturday evening. Well, the answer is lots of people will rely on a thing called the Wells score, where you take various clinical characteristics, and if you score more than 2, it is likely that you have a DVT. Most clinical hospital facilities will have the facility to do a D-dimer test, and if your D-dimer is greater than 500, then you've probably got a confirmed diagnosis. But we would all accept that the absolute gold standard is to do a duplex ultrasound, and it obviously depends on the availability of imaging as to when you get that done. There is no doubt that certainly standard of care is anticoagulation, and certainly in most countries we have now moved over to using DOACs only. What is interesting, in the US, they still use quite a lot of low molecular weight heparin because of the cost of DOACs in the United States. This is another simple chart, and you will see this as the guidelines doing ultrasound, treating with a DVT. But the only question, if you have somebody who's got a very extensive DVT, a grossly swollen leg, and the clot is in the iliac segment, that you should think about, should we do a thrombectomy or thrombolysis, and I will come back to talk about that. One of the reasons you should use a DOAC rather than low molecular weight heparin and warfarin is that you don't have the issues with bridging between low molecular weight heparin and warfarin, and by using a DOAC at the very beginning, you reduce your risk of developing the post-thrombotic syndrome. Now, one of the challenges and one of the major debates certainly in the UK, and I fully understand in a warm climate, is whether people are prepared to wear compression hosiery when they are diagnosed with an acute DVT. Now, we have a bit of an international controversy here. NICE and the American ACCP guidelines very clearly, after the results of a study that was done in Canada called the SOX trial, say that you don't need to give it to people. The European guidelines and the Australasian guidelines and most clinical experts, including myself in the world, would recommend that you should use compression because there is actually reasonable evidence that it will reduce the post-thrombotic syndrome. Now, luckily for you, and certainly for me, I could have spent the whole evening going into tomorrow morning if we were going to talk about all of these individually. But I've here tried to summarize what is probably you should do with respect to where a DVT is in respect to its anatomical position. So if you take the calf, you should probably treat with anticoagulation for a minimum of 6 weeks. You might go to 12 weeks. Now, one of the catches with the calf is, if you look at the American guidelines, if they say there are just some mild symptoms, they will advocate just rescanning in a week's time before starting any anticoagulation. I think the majority of us feel that if their patient is symptomatic, you should definitely treat them with anticoagulation. If you identify an asymptomatic calf DVT, I think you then have to decide what's the best for your own healthcare system. Obviously, For the calf, no thrombolysis and thrombectomy. Compression hosiery, yes. Femoral, at least 3 months of anticoagulation. No to thrombolysis or thrombectomy, yes to compression. Iliac, 3 months. Occasionally thrombolysis and thrombectomy, which I'll come back to talk about in the second. Compression hosiery, yes. Upper limb, I haven't, and I'm not going to go into a lot of detail about this. I will talk to you more if anybody wants any questions about that as to the role of thrombectomy, thrombolysis, and then subsequent first rib excision. But no, the routine again would be for 3 months anticoagulation. For PE, again, minimum of 3 months anticoagulation, and obviously we can go into some further discussions about provoked versus unprovoked. And there is always a discussion with the haematologist. If you've got somebody who presents with a PE, you are obviously going to treat them, but should you or should you not scan the leg veins to see if there is a source? And you can argue and discuss what is the best for that. Now, there are some specific things that I've just really wanted to put up here because it is of interest as to what you do with patients who have got cancer. The standard teaching was that you should use low molecular weight heparin over warfarin. There is now a big body of evidence to suggest that using DOACs is as good as using low molecular weight heparin. So the answer is I would very much recommend to you that you use a DOAC, but only flip back to low molecular weight heparin if the patient with cancer is getting some recurrent symptomatology. Now, one of the other myths that I was always taught about people who had ports in, that if you ended up with clot around it, the first thing you did was take the port out. Well, that is not true. What you should do is just anticoagulate the port. If you want to try and save the port, you can put some thrombolysis in to try and save it if it is a very important port and you can't get access anywhere else. But the answer is the old-fashioned message is no longer true. Just leave the port alone. Now, one of the other questions that is often asked is how much should you investigate somebody who's never had a deep vein thrombosis before for underlying malignancy? The key thing is, and you might think this is a very stupid comment, is that certainly in various countries now, people don't listen to the patient, they just subject them to numerous investigations, and people have forgotten the art of taking a good history. And this is really quite important because all of the recommendations that have come out to date are that you should not do very expensive investigations. And I'm just going to walk you through a view what you should potentially think about doing with a patient. You have a patient who presents with a primary unprovoked VTE. Yes, listen to the patient and only really do simple investigations such as a full blood count, use knees and a chest x-ray, and maybe the occasional sex-specific cancer tumor marker. There is absolutely no indication to do a CT scan or a PET CT because while you might identify the cancer earlier, it does not affect their overall mortality from cancer or from all causes. So that's all I want to say about the cancer patients. I'm going to say a little bit about the patients who have a thrombus in the iliac segment. These patients will very much have a markedly swollen leg, and the question is, should we or should we not do thrombolysis or do mechanical thrombectomy? You obviously need to take a history and examine the patient and then do some diagnostic investigations. Now, the key things from the history are how long have they had the clot, because if you're going to do thrombolysis, it can only be 2 weeks. With some of the newer thrombectomies, such as clot retriever, you can probably go up to 12 weeks. And you've also got to decide on the severity of the symptomatology. The diagnostic investigations involve duplex ultrasound, MRI, CTV, and the MRI may allow you to age the clot to decide whether thrombolysis or thrombectomy is possible. And it also gives you some judgment on the extent of the clot that you're treating. So, you may say, well, he said that we should think about that. These are where the present guidelines are with thrombolysis. And as you know, thrombolysis comes with bleeding complications. And all of the randomized controlled trials, as at the moment, show that thrombolysis has no benefit in terms of the post-thrombotic syndrome. Some people will argue that is because the trials used the wrong primary outcome measures, but that there is undoubtedly a major bleeding risk. But if you have a low-risk patient, and you carefully select your patients, you should consider it. And with the new thrombectomy catheters where you're not using lysis, you do not have the same complications with bleeding. So, key things, you need to look carefully, and that's why the listening comes in as to what you do with these patients. Patient selection is key, and mechanical thrombectomy is the answer. Now I'm going to take you through, inverted commas, another theoretical case. You've got a patient who has a grossly swollen leg and is in pain. Can't overemphasize this issue of listening. Initial treatment is to compress the leg, either with stockings or bandaging, elevate the leg. It's get them to walk, but to get them to elevate and anticoagulate them. There will be a cohort that will improve, and you can continue with that improvement, and they will go on in a conservative manner. However, there will be a cohort that have no improvement or worsen. There will also be a cohort of patients who present with a grossly swollen leg, and that leg is at risk, and it has something called phlegmasia cerula dolens. And for these two patients, you should think about offering them mechanical thrombectomy to get the clot out. This can now be done as a day case procedure, does not involve the need, as you do with thrombolysis, of needing to go to ITU. But remember, these are a very small percentage of the population, because the vast majority will get better with optimal conservative management. So, one of the take-home messages, and there is a World Thrombosis Day every October, and I'm just about to finish, so I'll come to your question in a minute. My main plea is, don't forget VTE in your patients. One, particularly for the prophylaxis, particularly with respect to treatment. And the answer is, I am more than happy to take any questions, and thank you very much for listening.
So I had a question about basically lines which you mentioned that anticoagulation can be given through lines if you suspect there is thrombosis. For example, in community, when the patients are discharged on big lines with long-term antibiotic care, whatever, and they sometimes get blocked, should we attempt anticoagulation, or should we just ask them to put a new line because it's an expensive thing in here in Pakistan?
Well, I think you've got two options, and it obviously does depend on the setting. When I was a junior doctor, we used to do all sorts of tricks trying to flush them under high pressure, and I think I've even been known to put a wire down. I deny all knowledge of that, but that is the truth of it. I think you can also, if it is a very precious line, you can put some TPA down it to try and save it. But there was a mantra in the past that once it is occluded, that you should yank it out as soon as possible. That is no longer true. The answer is to anticoagulate and take it out when you are out of the acute situation, or you may want to do it at the same time as you're going to put another line in. But I think you have to make that judgment call as to how precious that line is and what are the other access opportunities. Obviously, if you've got subclavian lines and you've got somebody who's on renal replacement or other things, and this is blocked, this is blocked, this is blocked, and you've either got to find the vascular surgeon to get you some bizarre access, then I think you've got to try everything in the armamentarium to get it to them. Any other conundrum? So I can talk a little bit about upper limb VTE. In a way, a lot of the same things apply as to what we talked about the leg, is that if you've got somebody whose dominant arm is very swollen, there again is an argument for maybe thrombolysis or thrombectomy, but I think it's really quite important that you need to weigh up the risk benefit. Because if you are giving thrombolysis, I certainly quote patients at 1 to 2% risk of having a cerebral hemorrhage because of the thrombolysis. That might be slightly excessive, but I think it is very important that the patients know that.
So this is just an overview of the hospital. So to begin with, Novacare is a partnership between deep Pakistani patient capital and international healthcare management expertise. So I represent an entity called Andalus Holdings, which is the managing shareholder for Novacare Hospital. We are healthcare investment and management professionals, have a track record in building and gestating projects like this. And we're quite fortunate to have as our anchor investor Maple Leaf Cement, effectively, who bring not only a legacy of building strong enterprises in Pakistan, but also share the vision around building a very, very high quality hospital in Pakistan. And obviously one of the main differentiating factors is the partnership with Imperial. So again, we're quite fortunate to have the affiliation. It was signed in 2024. Some of the gentlemen are in the room today, and you'll be able to find them and chat with them. And this affiliation adds significant value to Novacare and to the health system in Pakistan. Just to give you tangible examples, so the team from Imperial is involved throughout the design and planning of the hospital, from establishing the clinical services to looking through the architectural setup, the medical equipment, technology, and then also staffing. Once we're operational, they'll play a key role in the clinical quality assurance. Once a year, a team from Imperial will be on site to conduct a peer review and a gap analysis. And the fundamental construct is that we operate Novacare Hospital Islamabad to the same standard as they would expect the 5 Imperial hospitals in London to operate. In addition to that, there's a lot of opportunity for more structured cross-collaboration. So observerships, individuals and teams from Pakistan going to London to learn and to grow, and obviously teams coming the other way around as well. Integrated patient care, so providing a structured path where the clinicians actually collaborate as one global team to provide second opinions and virtual consultations and so on, with also a referral pathway for pre- and post-operative care in Islamabad, and the acute care being provided in London. So, and I don't think we need to introduce Imperial as such. The Imperial College Healthcare NHS Trust, it's one of runs 5 hospitals in London, including the St. Mary's Hospital, Hammersmith, Charing Cross, and we're quite fortunate that they're also associated or affiliated with the university and an emerging biotech cluster in and around Paddington that is home to many medtech and pharmaceutical and life sciences companies, and it gives us access to that innovation ecosystem as well. We'll just talk a little bit about Novacare. So we have a dual mission and purpose. Our core mission is around our families and communities to enhance years of quality life. But the second part of our mission is equally important, which is to create an unrivaled professional environment. When we were setting up the project, the one thing we kept hearing was, especially from some of our colleagues and friends who are practicing abroad, that they would like to see an institution within Pakistan that operates to the same level of infrastructure, the same level of institutional excellence, the same types of systems and processes that they're used to. And that's very much our mission to build an inspiring institution within Pakistan that some of our best healthcare providers would like to be part of. And we're starting with one hospital in Islamabad, but the vision is very much to build a countrywide health system, 3 acute care hubs, one each in Karachi, Lahore, and Islamabad, and to support that with enabling verticals, whether they're around medical education and training, whether it involves taking care into the community in an ambulatory setting, embedding sort of home and remote care and technology throughout. Just very quickly on the project, so we are building the hospital. It's under construction as we speak on a 50-canal piece of land in DHA 5. This is down the Islamabad Expressway towards Rawat on the left side if you're coming from this side of town. And this is what the building looks like as of a few weeks ago. So we finished the grade structure on time against a very ambitious schedule. And at the moment within the building, all the engineering work is happening, the mechanical, electrical, plumbing, HVAC, life and fire safety, and ELV works. And by around March or April, we'll start to finish everything. And the plan is actually to open and to commission on the 30th of September next year. Just a few things about the project. So our lead design firm, architectural firm, is a institution called HKS. They're based out of the US. But they have 29 offices globally, and they're generally ranked among healthcare architects as the #1 firm. And that means, not only do they design a good aesthetic, they also understand how healthcare works, what the requirements are around patient flows, around biomedical engineering, infection control, safety, all of that is embedded into every aspect of the design. And these are just some renders in terms of what the facility will look like. So this is from the main entrance and the on-grade parking. This is from the other side as you're approaching it from DHA Expressway. What you see there is our main emergency entrance. And one of the iconic features that whenever we take also visitors to the site, and it still needs to be finished and dressed up, but one of the features is this iconic atrium that straddles these 2 buildings. We have the inpatient building on the right side and the outpatient one on the left side. And this is just to give you a flavor or an idea of what the inpatient rooms will look like. Again, the idea is to bring world-class design aesthetic within Pakistan. Ample daylight in all rooms. We're using curtain glass windows throughout because of the healing effect of being closer to nature. And we're also quite fortunate to be on a high perch, so we've got sweeping views of the valley looking out. On a clear day, you can even see the Margala Hills from the hospital. So this is just the hospital in a few kind of facts. So 243 inpatient beds to be precise, with 68 critical care beds. This is just phase 1 of the project. We've actually master planned it to expand to 450 beds. Very large outpatient consultation complex, 115 clinical and treatment rooms, 11 operating theaters, an emergency with 25 bays, full service oncology program, including 3 bunkers for radiation oncology, almost 600,000 square feet of built-up area, ample parking, almost 500 spots. One of the features that is quite important to us is to build sustainability throughout the design. So this will be, inshallah, Pakistan's first LEED Gold and EDGE certified building. So everything that is designed is to be very, very efficient from a resource use standpoint. This is the clinical program. So in this first phase, it's a multi-specialty tertiary hospital with several centers of excellence, primarily around women's health, heart and lung, oncology, among others. But the idea is to provide excellent care across sort of all specialties and to do it in a team, in a multidisciplinary setting. And finally, we are looking to establish several firsts and domain excellence within not just broadly for safety and quality in terms of, for example, Joint Commission International. For us, that's almost table stakes. It's a given that we will be applying for Joint Commission International accreditation. But to give you some examples, in technology, we're aspiring to achieve HIMSS MRAM stage 7. And that is sort of the pinnacle of technology excellence. There are few hospitals globally that achieve it. And we have some of our colleagues from the technology side who can speak to this, but this means a completely paperless hospital where it's not just about the technology, it's also about the processes and the behaviors that enable safe and high quality care, and where you are benefiting from AI and ambient listening. I mean, there's a number of different applications and technologies that enable this level of technology excellence to be delivered so that everything is documented, but it's not a burden on clinicians at the same time. So yeah, I mean, that's just a quick introduction to the project. You can follow us on all of our digital and social media. I'm sure most of you are already doing it, but we're on LinkedIn, YouTube, Instagram, Facebook, and soon also on X, on Twitter. And that's where you can catch sort of updates and news on the project. So, yeah.
Thank you, Khalid. For the clinicians among you, we know that JCI is normally perceived as a huge bureaucracy. But to make you happy, we will also work on clinical outcomes that will give you feedback directly on how your performance is and how we can improve. So I think that's also quite innovation in Pakistan, to take the clinicians very serious in their work and to support them in the most, elaborate way we can think of. So thank you very much. I think that's the end of the evening, but the professor is still here. Always, if you have questions, please feel free. Otherwise, send us an email, give us a call. We're happy to answer your questions and queries. Thank you very much for coming, and hope to see you soon back in our hospital. Thank you.